In this presentation, I will talk about 4 different cases regarding 4 different tongue disorders. But first, the classification of tongue disorders based on their etiology can be congenital or acquired. The acquired tongue disorder, the acquired tongue disorders can be traumatic, infectious, or syndromic, which means they are associated with other systemic conditions. Also, they can be neoplastic or due to other local factors. The first case is for a 16 months years old boy who presented to an army hospital with chief complaint of feeding problems. He was not able to close his mouth properly and he was constantly drooling. He had noisy breathing at rest and respiratory distress in the supine position. On examination, he had large globular tongue with no associated features of palpable hepatomegaly nor other organ enlargement. The patient diagnosed with macroglossia. Now, quick overview over macroglossia. It can be pseudo-macroglossia or true macroglossia. The pseudo-macroglossia includes habitual posturing of the tongue or low palate and decreased oral cavity volume, deficiency in the maxillary or mandibular arches displacing the tongue outwards, retrognathism, and hypotonia of the tongue. True macroglossia can be congenital or acquired. Congenital, such as hemangioma, lymphangioma, or syndromic, like Down syndrome, rare genetic syndromes, congenital hypothyroidism, primary amyloidosis, idiopathic muscle hypertrophy. The acquired macroglossia, such as acromegaly, sarcoidosis, diabetes, syphilis, trauma, and malignancy. The symptoms may include stridor, snoring, or feeding difficulties. Tongue may protrude from the mouth, causing air obstruction, also causing difficulty in eating, swallowing, or sleeping. Here is another picture showing indentation all around the tongue, which is indicative feature of macroglossia. The management of macroglossia is by identifying the etiology, or if it's unknown or neoplastic, we go for surgery. Our second case is for a 61 years old male patient presented with no known allergies or medications. He showed hemangioma on the left cheek. He reported daily intake of wine, but he doesn't smoke. He consulted for exophytic formation on the dorsum of the tongue. The patient reported that the lesion had arisen 46 years ago with little increase in size during this period. On examination, the clinical examination indicated a lump in the lingual mucosa located in the left paramedial position, elongated and slightly fissured, deep reddish in color, alternating with paler or pinkish areas. The lump was firm to palpation, non-fluctuant, not attached to deep tissues, painless, and non-bleeding. The differential diagnosis includes erythematous candidiasis, hemangioma, median rhomboid glossitis, amyloidosis, granular cell tumor, erythroplakia, and squamous cell carcinoma. An incisional biopsy was taken and sent to the lab, and the patient diagnosed with median rhomboid glossitis. Candida culture tested positive and indicated the presence of Candida albicans. In view of clinical characteristics, we obtained an incisional biopsy, which was stained with hematoxylin eosin and PAS stain. The PAS stain was positive and revealed the presence of hyphae in the upper layer of epithelium. The lesion was thus diagnosed as rhomboid glossitis with the presence of Candida albicans. The patient treated with fluconazole for 2 weeks at 50 mg per day. The patient consulted again a week after termination of the treatment. Samples obtained at this visit tested negative for Candida albicans, and the lesion showed reduced redness and was less raised than previously. The third case is for a 73 years old woman presented to restore her missing teeth. The patient had undergone complete gastrectomy 10 years ago without cobalamin supplementation. On examination, her tongue has a smooth, glossy appearance with a pink background. The lab blood tests showed macrocytic anemia, and her serum vitamin B12 level was reduced. The patient was diagnosed with atrophic glossitis, which can be related to iron deficiency anemia, pernicious anemia, B12 vitamin deficiency, unrecognized and untreated celiac disease, which often presents without gastrointestinal symptoms, or other factors such as xerostomia. The management of this case depended on the etiology, and in our patient, he had vitamin B12 deficiency. After supplementation of vitamin B12, this is the result before and after. As we can see, the tongue has reobtained its normal appearance and normal texture. The fourth and the last case is for a 5-year-old female patient who was referred to the outpatient clinic complaining of progressive dysphagia to solid foods. Her past medical history was insignificant, but her mother denied any medications during her pregnancy. On physical examination, it was noticed that she had 3 to 4 cm midline, smooth rubbery, and reddish mass at the base of the tongue, with overlying telangiectasis. Neck examination revealed neither palpable thyroid gland nor any other palpable masses. The differential diagnosis of this case includes lingual thyroid, vascular tumor, benign tumor. Thyroid function tests demonstrated euthyroid levels. Other lab tests were within normal limits. Thyroid ultrasound scan revealed the absence of thyroid gland. Technetium thyroid scan revealed isotope uptake at the base of the tongue, and no uptake in the normal thyroid location. Fine needle aspiration biopsy from the mass revealed normal thyroid tissue with a few colloidal changes. Quick overview on lingual thyroid. It is an uncommon abnormality of migration of thyroid gland. It is 4 times more common in females than in males and seen in young adults. 70% of patients lack thyroid tissue in neck or have hypothyroidism. Thyroid carcinoma arising in the mass is rare and almost always in males. The etiology of this condition is due to failure of migration of thyroid gland to the front of neck and remains in the base of the tongue. The management of lingual thyroid in most cases require no treatment, or surgical excision or radioiodine therapy if adequate thyroid tissue in neck, or if lack of thyroid tissue in neck, then excision and onto transplantation. Thank you so much.